October 30th at 12 p.m. and we are convening in a board workshop of the Board of Trustees of the McAllen Independent School District. Will be held Monday, October 30th, 2023, beginning at 12 p.m. in the boardroom of the Administration Building of the McAllen Independent School District. At this meeting, there may be discussion by the board on the items and subjects listed as follows. Item 1, call the meeting to order. I have done so at 12 p.m. Item 2, public comments. There are nobody signed up for public comments. So I just want to thank everybody for coming and flying in town for this. Usually this is just a meeting with HR committee, and there's usually just 2 trustees, and I appreciate you allowing us to do this in such a formal manner. We have 4 new trustees that just got elected, and so they really wanted to hear about this and how this impacts our fund balance and everything. And so there are some that are listening via, they don't have their cameras on, but they'll be listening when they can, because everybody, as you know, everybody's working. And so we did it during lunch, hoping that everybody could come in and out. So you might see trustees pop in, pop out, but we do have Trustee De La Garza. She's actually been on the board, been president of the board back like 10 years ago, took a few years off and came back on. And myself, and I believe Trustee Pena will be joining us at some point. But I will now turn the presentation over. Item number 3 is Blue Cross Blue Shield and Araya prescription status presentations. Dr. DeWills.
Yes, the district sponsors a self-funded medical and pharmacy plan and contracts with a third-party administrator for administration services. The representatives from Blue Cross and Blue Shield of Texas, TPA for the medical plan, and Araya RX, TPA for the pharmacy plan, will each review the plan utilization.
Okay, well, thank you very much, and thank you for being here, and thank you for the opportunity to speak with you all. We're going to go over our semi-annual financial report, so I'm going to turn it over to Vicki, and if you have any questions throughout the presentation, please let us know. Thank you.
All right, thank you, Cindy. Again, my name is Vicki, so we're going to level set. I think we have 30 minutes set for the time, so slow us down if we go a little too fast, and stop me at any time and ask any questions that you may have. So just to advance to our data parameters page, let's look at the parameters around which our data was pulled. So our current reporting period is going to represent claims from January to June of 2023. This will not include any runouts. Our well-being management, which will be covered by our clinician, is going to run that same data format from January to April, incurred and paid claims through June. The benchmark that we will be comparing to is K through 12 and Rio Grande Valley. Our high cost claimant threshold is $50,000. And I would like to say this is a medical claims only review. So any pharmacy that's mentioned is pharmacy that's billed under medical. That could be inpatient, outpatient, or professional services. Okay. We can go ahead, go to the next. All right, let's jump into our first slide, our executive slide here. If you will look on the left-hand side, we're going to look at your quarter 1, which is defined as January through March, and we're going to compare that to quarter 2, which is April through June. So under the key indicators, you'll see your paid per member per month was $313.56. When we look at that in quarter 2, we see there was an increase there from $313 to $352 per member per month. Your total paid, we see this increase of 5.4 from 4.8 in the first quarter. And your total claimants in quarter 2, though, we do see a reduction in those claimants that we reviewed. Our next category, the diagnostic category, we have the prevalent diagnostic categories there. It's cancer, the neoplasms, and infectious and parasitic. And for the newer members, the infection and parasitic category is a category that we introduced to house our COVID-19 patients under. So that's what we saw. As we go on and as we get in later in the year, you'll see COVID is not the thing that's chasing. There are other categories in that area, such as Ebola, flu, any kind of communicable diseases fall under that category. So there we see our total paid in quarter 1 was $1 million, with that slight increase of 0.4% over in quarter 2 to 1.4. Your high cost claimants in quarter 1, there were 9 of those. In quarter 2, there were 9. These may not have been the same 9, but they reached that $50,000 threshold. That paid paid amount did increase to 1.4 in the second quarter. Chronic conditions in the population, we're still struggling with hypertension. That's there. The quarter one is 944 claimants, and quarter two is 961, with paid out of 2.3 million in quarter two, which is up from quarter one. Any questions? Okay. I'll turn it over to our clinician. Our next slide. Carrie Ann.
All right, so this is the executive summary for your well-being management and EAGLE program. So it's kind of like your report card. It's showing how we're supporting and engaging your members, and then the big number at the bottom, what the plan is saving you, the program value itself. So I just want to point out on here, you'll see the light gray, the prior data, that is from last year for the first half of the year. And then benchmark with the well-being management, with my part, it's the benchmark is across all Texas Enable accounts. So you can just kind of see where you're comparing. So we'll start with supporting. You're going to see here that 51.6% of your members' households have had a program interaction with an average interaction per household of 3.1. So interactions are any program activities with your members or on behalf of your members. So some of the examples of interactions include those well-on-target self-directed courses, utilization management reviews, or program participation. There is, at the end in the appendix, there is a breakdown of all the different interactions if you want to see how many, for each of those interactions listed. Next is your engaging, and you'll see that 7% of your members were clinically managed. And this means managed by a clinician. So it includes case management and utilization management. So that number, you can see, it's well above last year's data and this year. But then the next one, the participant engagement at 87%. This is what is so great to see, because this is not common among all accounts. So to see it this high is really awesome for me. So this is the amount of members identified for programs and then have decided to engage with those clinicians. So that tells me that your members are answering the phones when we're calling and participating with nurses. They want to take part in their conditions. So this is a great number. So whatever you're doing, keep doing it. And then that leads us to the program value, the savings. And you'll see the PEPM was 2581, which was significantly increased from last year. And that can happen sometimes with those medical pharmacy drugs because they are pretty costly. To the right is that breakdown of the PEPM. So your first one is inpatient and that was 247 PEPM. And inpatient these savings comes from our utilization management nurses working closely with facilities that your members are admitted to help facilitate any potential early but safe, of course, discharges or being able to move them to those lower levels of care. Outpatient utilization management at 249, and this is savings from that expanded list of prior authorizations. So making sure services are medically necessary, making sure less invasive things are tried first. Medical pharmacy at 1217, and this shows that value of our specialty review unit and then the site of care navigation team, really making sure that the right drugs, the right dose, the right time, and the right location are being utilized for each specific condition. Medical program participation at 674. So this savings comes from a couple different areas. One is from that 24/7 nurse line when we're able to redirect to a lower level of care. And the other is from decrease in admissions when those members have been triggered as risk of readmission. So that's from specific conditions or diagnoses in the hospital. They may be at risk for readmission within 30 days. So that's when we reach out to them and try to prevent those readmissions. And then at the bottom, you'll see behavioral health, and that's 194 PEPM. And that just includes everything behavioral health. So that's your inpatient utilization management, outpatient utilization management, care coordination and early intervention, program participation savings, and claims analytics and processing.
Any questions? The PEPM is per employee per month. If when you hear PMPM is per member per month, that includes the dependents and the employees.
Thank you, Carrie Ann. Thank you, Tita. We'll move on to our next slide, our financial overview. So on the left-hand side of the slide, you'll see the metrics listed out there. Well, what I've done is reviewed your data from January to June. It's broken out in quarters, but it's January to June in those totals. I did highlight two of those metrics for you, the discount, which for the period that we're covering was 35.4%. And then, of course, you're paid up through June, which was that 10 million below. If I can direct your attention over to the right-hand side of the slide where we have the network performance, you'll see your discount percentage for the in-network providers is at 74.4%. That roughly equates to, for every dollar that was billed, your portion was about 25 cents. And then that discount, which we mentioned earlier, and the claims paid with in-network benefits were 99.8%. Any questions there? All right. Let's move on to our next page. This is where we're going to see what is the story here. With McAllen, it is the high-cost claimants and the cancer patients. That is going to be your story. That is going to be the story that you'll hear when we return. But if you look at the graph at the top of the page, your high-cost claimants versus your non-high-cost claimants, high-cost claimants are denoted in the dark blue, and the non-high-cost is that light blue, and they look great there. So neoplasms, again, we see that spin, followed by infections and parasitic, which Carrie Ann will give us some more information on that category here in a minute. Going back over to our circulatory and endocrine. Now, if you will look at that second bar where we see health status there, and you're seeing that non-high-cost claimant is more prevalent there, this is a good thing, because that means that your members are going out and getting those well care checks, their annuals, they're getting the COVID shots, they're getting their flu vaccinations, and all of those preventive type services that they need, and cancer screenings fall into that category. So that's actually a good thing to see that non-high-cost claimant number where it is.
What did you say dictates a high-cost claimant, a threshold, you said 50,000?
50,000.
Per year, per quarter, per?
In some cases, if we're referencing quarter, it's in that quarter. But then if I say like January through June, that means that member met 50,000 from January to June. That's why that number can be different. So you could have a member that met in the first quarter 50,000, but their payout or their bills for the next quarter didn't total up to 50,000, so you wouldn't see that. But if I look at it January through June and we look at both quarters, they may have met the threshold. That's why you'll see that jump in the number.
The same, no, not the same.
Trustee De La Garza, you have a question?
Yes.
Go ahead.
No, she was just showing me.
I was just showing on the high claimants that it says 9, but we don't know if it's saying 9.
Right, that's exactly right. Yes. Good question and good clarification too. The top 10 diagnoses, if we look at the bottom of the page, I did list your top 10, but I'm going to review your top 5. So the Z51, other medical care, that includes radiation, chemo, immunotherapy. You had 41 claimants, and that medical pay was $539,000. I will tell you, even though you see those 41 claimants, you have one member that makes up about 46% of that spend at $246,000. Carrie Ann will give you guys a little more information on that in a minute. So that is the bulk of that, even though you see those 41 claimants. The next category, the diagnosis category, infections due to other mycobacteria. You have one member there that is a high-cost claimant. We'll cover that for you as well. The non-insulin dependent diabetes mellitus, the malignant neoplasm of breast. Remember I said our story here is cancer and our high-cost claimants. And then the special screening examinations for neoplasms. We expect to see that number because of the cancer patients that we're reviewing. And Carrie Ann, if you can give us a little information on that.
Yes.
Claimant that falls in Z51 in the second.
So I'll start with the second one, the mycobacteria. This member was the same member that was on your top 10 from 2022. and he remained as the top one for this time period also. So it was mycobacteria pneumonia, and this member is no longer on your plan. For the second
Can
one.
I ask something? I'm sorry.
Yes,
When you say member, that could be an employee, but it could be an employee's spouse or
Correct.
dependent. And do y'all ever break that down too to see, is there, okay.
We can, definitely.
So he's no longer, but that's, it would be interesting to see.
Are you wanting to know on him specifically?
No, just,
Okay.
yeah.
Can someone take that notes?
Ms. Alicea, we do routinely get reports that have it broke down
Yeah.
that way, so
Okay.
when
So
we
you
report,
know.
we can definitely share that.
And then the one that Vicki had mentioned, the bulk of that Z51 from that one member, that was a member with breast cancer that was also on the high-cost claimant list from 2022. Long-term treatment was expected with her, and we continue to see that long-term treatment there also.
All right. Any questions? All right, thank you, Karen. Let's go on to our next slide, the high-cost claimants. The top part of our slide there, those top numbers that you see, that represents our current period, January through June. The lower number, the number underneath, represents the prior period, same time period. So it could be that cost, or it could be the benchmark. So for January to June, the high-cost claimants, there are 27 in this reporting period. Your total plan spend in high-cost claimants is $3.2 million compared to 1.7 in the prior period. The high-cost claimants as percentage of total membership makes up about 0.53%. Our average plan spend per high-cost claimant is $118. That is down from the benchmark of $129. And our high-cost claimants as percentage of total plan spend is 31.2% compared to the benchmark.
That benchmark, is that just what we've been doing, or is that compared to other school districts our size?
That's compared to your K through 12 in this case. Now, in the annual that we do, I will show you a side-by-side. We'll show K through 12, and it will show Rio Grande Valley. That is what has been asked. Okay. But this is K through 12. If we look at the bottom of the slide, the top diagnostic categories there, the cancers there, neoplasms with that spin, infectious and parasitic, endocrine, circulatory, and congenital chromosomal and congenital abnormalities. Carrie Ann, can you provide a report with just a little information on that infectious and parasitic?
So the infectious and parasitic, that's that mycobacteria pneumonia that we mentioned earlier, is that same member. And then on the bottom, the congenital abnormalities, that was an infant with multiple cardiac malformations. So that infant has already undergone one surgery, and over the next couple of years will undergo a few other surgeries also. So you will continue to see that member as a high-cost claimant.
Thank you. Any questions? All right. Our next slide will be covered by Carrie Ann.
All right, so this is kind of the list of your members and the conditions that they have. I know we did this one last year too, so we'll do a little bit of comparing with just the 6 months to the 2022. So across the top, you'll see that 25.8% of your members have at least one of those conditions listed on the bottom, and 22.1 are clinically managed. Again, that's by a clinician with case management and or utilization management. And just pointing that out, that is again above benchmark. So your members are getting help from nurses. Now, in the chart on the bottom there, you'll see the conditions that the members have. Those top 3, high blood pressure, diabetes, and low back pain, those are right in line with your data from 2022. If you look to the right in the light blue, that's how many are clinically managed. In the bright blue, how many have been identified for programs. So, and that just means because those members with high blood pressure, they may not need help. They may just be taking their medication and be doing fine. They may not need a nurse to call them and see what other resources they need. So once we identify that they do, that's where that number comes from. And it may be, It may be that they have multiple conditions. They may have had multiple visits to the ER. They may be a high-cost claimant. Those are some things that would trigger for us to reach out to them. And then how many of those members identified are engaged in programs, and that's in the teal bar. And what stands out to me here is these numbers are almost the same as they were for your entire year for 2022, and we're only halfway in. So again, this is a great thing. Your members are interacting with our nurses, and we're able to provide them with any assistance that they need. And some of the things that they're doing when they're talking is they're making sure they can get to their doctor's visits, that they have a follow-up plan of care. They're assessing social determinants of health. Do they need a behavioral health clinician to help them in their journey with their conditions? So they're utilizing those resources. So again, great job getting the word out to your members to answer our calls and to engage with our clinicians.
Questions?
What, at the very top, attributed savings, what does that mean?
So that's back in that first slide when we had the program value. So it's part of that. It's just of the members with these conditions, how much were from these members. So it could be that inpatient utilization management savings, the outpatient medical pharmacy. It's just broken out a little bit different. This just is not in addition to that first slide of the program value. It's just of the members with the conditions.
So the members with the conditions, it's 1,300 out of 5,100, but then clinically managed, it's only 291 out of the 1,300 that are identified. And how do, would it be best if we increase that number, obviously?
Well, if they're identified, it's going to be from those certain triggers. So that would be if they're using the ER multiple times, if they're high-cost claimants, if they have multiple chronic conditions. We have a list of triggers that will fire for members, and that lets us know we need to reach out to them right away. They can always call in and also be engaged with a clinician, but for the outreach, when they hit those triggers, that tells us we need to reach out to them. They need the assistance.
Thank you.
Oh, I'm sorry.
My fault.
Any additional questions, clarification? All right, let's look at our ER activity on our, actually, this is our last slide here. So, this is interesting, interesting. So, our ER visits in Q1 compared to Q2 actually decreased. That total does not add up if you were looking at that and going, why isn't that total adding up? Well, when we look at the ER patient, this is a financial overview. So you could have had members that had gone to the ER multiple times, and so they wouldn't be caught in the Q1, Q2, but they will be caught in the unique number, in that total that you see. So that's why that number may vary some. So what we saw was your ER paid actually went down in Q2. This was interesting, got me digging what's going on here. Well, when I looked at your 2022 data, for the same time period, you had 111 infectious and parasitic visits. Remember, that's that category we created for COVID. 2023, infectious and parasitic visits to the ER were 39. 2022, your health status, that's where you're getting that testing. I do believe the last time we were here, members had to, employees had to go and get tested if they got a positive test and go into the ER. So you had 79 of those visits at this time last year with 0 for this period, this time. So overall, just looking at that data, it looks like that's where we saw that shift in your ER visits and why that cost has come down. Is that good story? Good story. So our top ER facilities by quarter, you'll see those listed below. Members, McAllen Hospital, Rio Grande, and Doctors Hospital Renaissance. Now, any questions there? And then just
That includes the McAllen Heart Hospital, or do they just choose McAllen Medical?
I only pulled your 3, so
No,
we don't. So.
I think the Heart Hospital is part of McAllen Medical.
Okay.
Health system, right.
Okay. Thank you. And just Just to note in the appendix, because I know we have some newer board members here, I did go back and add in 2022 data from some of these slides, just so that you have it as a comparison for this time period. So if you're wondering or have questions of what do we look like in 2022 during that time period, that's there. And if I have not included one that you need, just reach out to Tita and I'll definitely get that over to you. All right, so that puts us at 12:26, a couple of minutes. If you have any additional questions, we'll be happy to address those at this time.
So if they're going to DHR or Rio Grande Regional or McAllen, the other hospitals, that means that they accept Blue Cross Blue Shield? These are, or no?
Yes,
Yes.
Okay.
all the major hospitals in the valley, from Bronzeville to Stark County Memorial, they're in the network.
But it's just, it's different, the amounts they pay out and the different, okay. That's the problem that we always have.
Yes.
And it depends on the service.
Right.
Services. So they're
But that's
negotiable.
always been the issue, is the price that we pay at different hospitals is different.
Yes, it is. It is different based on their specialty.
Yeah.
Mhm. Yes, ma'am. Are there questions that they're coming up?
In,
Oh, no,
in
that's
your,
just translated in Spanish.
Oh,
in the appendix, and I put it up on the screen, page 16 and page 17, it has the top providers, it has a longer list of hospitals, both on an inpatient and outpatient basis.
Thank you, Andy.
So, as far as ideas or thoughts on cost savings, is this the meeting where we have that conversation, or?
So we can certainly speak about any of the things that we're doing ourselves through our office, and then they can speak to some of the engagement tools, if you like. I mean, as far as what our office does, we continue to do our education. We're doing more of the on-campus presentations. Ms. Amada is out there at all the campuses, either making presentation or at least making herself available to help answer any questions, provide information. And then we, of course, have all our communications we do through email, periodic flyers, notices. We post things on campuses. So all those efforts are continuing. And then, of course, we have what's built in through Blue Cross for, as you mentioned, all those outreach efforts that they do.
Does it have in here, in the appendix, how many people are actually on our plan? Like how many employees, how many members? Is it broken down that?
There was one slide
Does it have a
that
slide that has a number?
had the 5,500.
It's not gonna do it.
Oh, it's only members with, we have,
Well, it seems
Your,
like we have,
your average membership is 5,099.
okay, so that's that number, okay. But out of that, do you know how many of those are actually just employees?
Your employees are 3,249.
3,240.
Yeah, there you go.
Okay.
As Carrie Ann had said, I mean, you guys are doing a great job educating. The fact that they're participating in some of these programs that we have, that's huge. That's something that, you know, it's a consistent challenge to get them to enter the phones or look online, or, so the efforts that Andy and his team and our on-site rep and Chica, what they're doing is, just to educate has been, it's been a big help, and you can see the results.
Thank you. Okay, we're
Any
ready
other
for.
questions?
Just real quick, I'd like to thank and recognize Hobie. Hobie does an outstanding job with our families and our parents coming in. And what is this EOB and what is it telling me and all this stuff? So thank you, I always tell you, but thank you very much for everything that you do for our staff and our families, for that's super critically important. So thank you.
Yeah, I was telling them I thought they were employees of the district because I see them everywhere. So-
Well,
Almost,
we,
yeah.
in a sense, we are, but we're paid by Blue Cross.
Yeah, no, that's wonderful, yeah. And that's probably why those numbers are so high. The good numbers are high, not the bad numbers are high.
Yeah, I did go out to the schools August through October. I did go out to the schools and I interacted a lot with the staff. And and, you know, they have a lot of questions, and I'm able to answer that for them, so I think they complement a lot, you know, the fact that I'm going out to the schools.
That's appreciated.
Yes.
Well, thank you again. Thank you for the opportunity.
Thank you.
Thank y'all.
We're here to help
Thank
you.
you.
Thank you very much.
Stay warm.
Thank you.
Yeah, definitely, 92 to 45. I'm confused. I told my husband, I was like, I wonder if it was gonna be so warm.
Yeah, yesterday was.
Oh, yes, I was here. I
Yeah.
enjoyed that.
Just in time for trick or treating though, so that's good.
Thank you, ladies.
Thank you.
Thank you.
Oh, sorry.
This is better than a murder trial. It's really about the same. And then what happened? And then what happened? And what did you see? And what did this person say? It's all the same.
Or be the detective, be able to trench coat, be the detective. But anyway, so I'll stop by. Yeah.
All right?
Yes.
Good afternoon. I'm Pat McLaughlin. I'm the president of Araya. I have Chris McAllen with me. He's the director of our clinical programs. Araya manages the prescription drug benefit for your employees and their families. We're going to go through a presentation today. We're going to focus on the third quarter of 2023. Not only do this every quarter for the district, we have actually 15 months of data to show you. We're going to go through the plan performance. I'm going to talk about most of the financial portion of it. And Chris is going to go into some utilization review, trends and things like that. We'll talk about one of the programs that we've been most successful with, reducing the cost to the district. We're going to talk about our digital member engagement tool, Clara, and then another program that we think that you might want to take advantage of to help you with the program. Chris is going to talk about that. There's also some supplemental reports at the end of the presentation. We'll open to detail on those. It's a lot of numbers. If you have questions, we can certainly talk about them. This report, for those of you who've been here before, you've seen this one. For those of you who are new, I'll walk through kind of what the data points are on it. What I'd like to do is show you what your utilization has been over the past 12 months. And you can see in the far right-hand column there, my glasses off. In the far left-hand column is just the month, and then the plan pay, what we're actually paying to the pharmacies, what the patient is paying, what Araya's admin fee is. The rebates are retrospective discounts that we get to the drug manufacturer. That's money that comes back to the district. Then the international program, what we're spending on prescription drugs that are being delivered to members from outside the country. And again, we're going to talk about that more in detail. And then what the net plan pay is. So it's plan pay plus the admin fee minus the rebates plus the international. That's what the net cost of the district is there. And then what we try to do, again, much like what Blue Cross does, is normalize that data for you, divided by number of members in the plan, because that's what we want to look at, because obviously the membership goes up and down. You can actually see back in October 2022, we had about 5,000 members, and now about 4,700 now. So as that goes up and down, you're going to see utilization go up and down, because people are using prescriptions, but you need to divide it by that number so you can do comparison. So overall, it stayed pretty steady through 2023. Well, we want you to look at that table below shows the same quarter in 2022 versus 2023. And you can see the plan spends down about 15%, claim counts down as well, but we know the membership is down too as well, right about 6.5%. But the plan spends down much more than what the membership is down, and that's because the programs that we've recommended and actually Mr. Silva's team has put into place, the international program particularly, has really dropped the overall cost down. The number of prescriptions has stayed about the same, which is a good thing, because that means we're not using any less prescriptions. We're not slowing access to utilization. We're just getting them for a lower price, the same prescription for a lower price, and that's reflected in that prescription dollars per RX. So that's cut down a little bit as well. So that's really where the change is. And what Araya tries to do is maintain the same level of therapy, but really get those medications for the lowest unit cost possible. And that's one of the big things that happens in the international pharmacy program. You can see the generic percentage has gone up a little bit, which is always good because the more generics we fill, that saves the plan money as well. Generic less expensive. But this one's a little bit misleading. Back in 2022, there was a lot of vaccines being filled. We're still realizing COVID back then. And vaccines are brand name drugs, and there were so many that they actually depressed what the generic dispensing rate was. We're seeing less vaccines being filled this year, so that's kind of brought it back up again a little bit. But it's still, 88 is a good number. That's where we want to be, and that 88 to 90 number is what we should be fighting. So brand name drugs, about 10% of prescriptions, and Chris is going to show us later on, most of your cost generics are 80-90% prescriptions are a lot less expensive. So overall, the plan is down to 8629 to the third quarter of 2023. But we've been with you since 2020. We actually have data from 2019. Your PMPM in 2019 was about $90.50. So after 4 years, we're still below where we were. And I'm going to show some inflation numbers here as well. So the plan is performing very well because these programs we put in place, and the district's done a lot of work, getting members involved in that and engaging in those programs. Any questions about this slide? I want to talk about inflation just for a minute. The drug manufacturers, they raise their prices every quarter, actually. And what we do is, every quarter we do a report, we look at all the medications that were filled a year ago in that same quarter, and what do they cost us this quarter now. We look at it for both brands and generics. We break brands and generics out a little bit different in two categories. There's specialty and non-specialty. Non-specialty is more your traditional oral medications, people picking up at the pharmacy. Specialty meds are ones that are usually self-administered injectables, a lot more expensive. So we break those two out to see where we're seeing the increases in cost. And you can see on the traditional brands about 3.89% over the course of the year. The brand specialty about 6%. In terms of dollars to the plan, 58,000, 65,000, excuse me, 68, 59. Keep my glasses on. Generics really stayed about the same, only about $400 difference there. There's also new drugs that are added to the plan, ones we haven't filled before, so we put those in there as well. But the real inflation is that bottom number, about 128,000. But that's annualized. So those drugs for the third quarter of 2022, there's the inflation on about $128,000 annual increase. So if you think about that, and a quarter of that would be about $30,000, we're on a 3% increase just in inflation. So it's about what it is every single year, 3 to 5% increase. So we're seeing those increases, but still the plan's PMPM is below where it was in 2019. So overall, the plan is performing financially very well in our opinion. I'm going to let Chris talk about some clinical trends here.
Sure, thanks. So Patrick gave kind of more of a high-level overview, and I'm going to go dive a little bit deeper and go over what the plan has been spending the money on and what I expect over the next year. Moving on to the next slide with the pie charts. We keep this slide in every presentation for every client. It really shows how Araya uses targeted interventions to focus on higher costing medications that impact less members. On the left-hand side, we have the claim count by brand and generic. The green is the generic claims, and the gray area is the single source brands. And single source brands include medications you're going to see advertised on TV: Trulicity, Farxiga, Mounjaro, etc. The gray area here, the single source brands take up about 11% of the total claim count, and this is from October 2022 to September 2023. On the right side, we see the plan costs. In that same area, those single source brands are taking up about 83% of the overall plan costs. So again, 11% of the claims count for 83% of the costs. So what Araya does is we try to focus on those single source brands in order to get more savings impacting less members than it would be if we had impacted everyone or impacted people that are using generics more. moving on to the next slide, this is kind of zooming in on those single source medications and looking more at specialty medications, most of which are single source brands. This is a complicated table, and I'm not going to dive into it too deeply, just in the interest of time. But briefly, the left side has the current utilization organized by plan spend descending, and this is from October 2022 to September 2023. And we can see the top medications here. On the right, we have the previous period, so 2021 to 2022. What I want to point out here is the gold star medications on the left. These are medications available via the personal importation program or ElectRx. And what I'm seeing, I have this report in every presentation, and what I've seen is that the starred medications are decreasing in number because as medications go to be filled internationally, their costs decrease and they fall off of this table. So it's really kind of showing the success of the personal importation program that we've had thus far. In the red box is a medication called Serdelga. The member utilizing this medication has disenrolled from the plan. So that medication, which was used by one person, cost McAllen $350,000 over the last 12 months. Going forward, I expect to see this drop off this table entirely, which is going to be just that much cost of the plan, that much less, because it won't be here. We can go to the next slide. This table showing the chart showing the top 15 members and what percent of the overall pharmacy spend these members are responsible for. Again, that top member here, $354,000, which really lines right up with the Sir Douglas on the previous page. That member has again disenrolled, so we should see that that cost be released from the McAllen pharmacy spend going forward. The stars here also represent members who have internationally available medications, and like I said before, this chart has less stars than it used to because members are going to use international pharmacy and they're dropping off of this. In terms of what we're seeing going forward and what I expect to see, I left in the box here, members A, G, J, and L are expected to not have therapies ongoing, either due to disenrollments, therapy completions, or terminations of those therapies. Their cumulative spend over the last 12 months was almost $500,000, which we're expecting to see drop off of the McAllen pharmacy spend going forward. And that $500,000 would lower the plan pay about 10.2%. So I'm looking for some pretty significant savings going forward, presuming no new therapies, no new high-cost therapies are started. Any questions on this page? All right. Going forward, the International Pharmacy Program or Personal Importation Program that McAllen has was started to be utilized in 2021 on a voluntary basis. But I'd like to point out how this works with the letter sent. When a medication is filled by a member that is available internationally, we send them a letter saying this is available for no copay if you get it filled internationally. This was, again, a voluntary basis in 2021. So every time someone got a medication filled, they would get a letter saying, please use ElectRx, which is the pharmacy network we utilize internationally. In 2023, the district implemented a mandatory international pharmacy program. So medications that we deem to be of a net benefit to McAllen are put on the formulary, and then if a member receives that medication, they're allowed to have 2 fills domestically, then they're required to fill the medication internationally. In 2023, the letter sent drops because members have already switched to using international pharmacy and therefore no longer need a letter each time. We also see the number of utilizing members in 2023 jumped up quite a bit because members were required to use that program. And the savings subsequently also increased dramatically. In the first 2 years, McAllen saved about $1 million in pharmacy costs. And then in 2023, up to September 30th, so only about 3 quarters, we see the savings is at already $900,000. So collectively, McAllen saved almost $2 million by using international pharmacies for their members. And this is really not really impacting the members in a way that is different than what they would usually do with any specialty pharmacy. Specialty pharmacies aren't local. You don't go to the HEB pharmacy and get a specialty medications. Those are delivered to your house. This is no different. Members are just sent from Canada instead of a domestic specialty pharmacy. Any questions on this? Patrick's going to discuss a rebate.
I talked in the first slide about rebates. They're retrospective discounts that we get from drug manufacturers. There's a preferred drug list in place. We set the copay so that members are, if they use the preferred drug, their out-of-pocket costs are less, not preferred, it's higher. So because we do that, the drug manufacturers send checks back to Orion, we pass them back to the district. We negotiate those every year, actually have a market check in place, and we look and we see if we can get a better deal, we go out and move vendors. So we're paid a certain amount per drug, whether it's a retail 30-day supply, a retail 90-day supply, or a specialty. So you can see what the numbers are per prescription that we're passing back to the district. Here's what the number was in 2023. We had an automatic built-in increase for 2024 with our previous vendor. We renegotiated that, and the new rate is there in 2024. So we're going from, for the example, the retail 30-day supply is $263 is going to be $305, or about a 16% increase. So I talked with this at meetings in the past, the way that Orion's contract works, as we get better pricing from the pharmacy network, as we get better pricing from the rebate from the manufacturers, it automatically falls to the district. They have to renegotiate with us or get a new contract in place. So in the middle of our contract, we're renegotiating to get better rates. This would be about a 20% increase overall for the district in the rebates. We don't get rebates on the drugs that are filled internationally, so if you back into the rebates, see they've gone down a little bit over the course of the year. They've gone down because the meds are moving to international. But for those meds that are still filled domestically, we'll still get rebates on those and be 20% more than we've got in the past. So we've got more source savings back to the district. I think it should be about a 20% increases, should be over $100,000 a year. Other program that we rolled out last year was Clara, our digital member engagement tool. We had Clara up and running before we brought it to the district. As you brought it to the district, we put some tools in place to make it even a better fit. The idea behind Clara was to give the member information on their smartphone so they could make it easier to manage the benefit. When you're a self-insured benefit, you use a TPA for the medical, TPA for the pharmacy. There's a lot of different pieces that put together. So, and a lot of places they go to get the information. We want to make it very easy for them, give them kind of a one-stop shopping that they can go get all the information. So the tool itself is loaded. It's a smart app, either Android or iPhone. They can look up the pharmacy network. They can look what their copay is going to be. They can look up if it's a PA or not. It also has some cool tools in that they can do interactions with providers. If the system shows them that they're on a drug, maybe it's not formulary, here's the formulary products you could use. They could actually message their doctor's office through the app. It'll send out a fax to the doctor's office, say, my plan pays for this, not this, can we use that? So we could push out, the member can push out information like that. If they're traveling, they want to use a different pharmacy, they can actually request a change of pharmacy as well. So there's a lot of tools built into it to make it easier for member to manage the benefit. As we roll this out for McAllen, we built in the international program to as well. So now when the member gets a prescription filled internationally, it'll show up with a little icon saying this drug's available internationally. In the same way they can switch from HEB to Joe's Pharmacy, they can switch from the specialty pharmacy domestically to the international pharmacy. In a couple clicks, they can push out all the information. I'm sure we can all relate to the fact that we always know exactly how the drug is spelled or what the dose is or which doctor wrote it. This pushes off all that information right to ElectRx so they can contact the prescriber and get the prescription moved over. So again, we're telling the member, here's medications that'll be lower cost for you, and here's the easy way to do it. In the end, it helps save the plan money as well. We just rolled out another level of functionality, and it allows them to shop for drugs that are filled domestically as well. So you've probably seen ads on TV for companies like GoodRx, where sometimes drugs are lower priced from pharmacy to the next. The same thing happens in Oria's contract. We don't pay every pharmacy the exact same amount. Again, Walmart might have a $4 special on generic this particular week. The new functionality in the app will let a member go in if they're taking a medication for cholesterol. Maybe it's at CVS it costs $20 and their copay is $7. If $4 at Walmart, they can see that now. Another member pays $4 and the plan pays $0. So it saves the member money and it saves the plan money. And again, the same thing. If they find it at a different pharmacy, a couple clicks and they can push that request out to get a prescription filled someplace else. So it's a great tool. We're doing a bunch of things with Mr. Silva and his team, helping try to get more and more engagement on this. Let people know they can use this is that even prospectively, in the doctor's office, the doctor writes a new drug, they can put the drug into the app and say, oh, doc, this one requires a PA, or this one is non-formulary, here's other alternatives, and the doctor can see it and write for a drug that's gonna match up better with the benefits the plan has in place.
Will local pharmacies be on that app? Like, is that just the big pharmacies, like
No,
the
no,
Walgreens,
every
CVS, that's
pharmacy's
everybody?
on it,
So if a local pharmacy like has that,
And a lot of times, that's the best price.
okay,
So, but now they'll know. So
okay.
they might be, because it's easy, you know, they're going to CVS, say, now we know they can, wait a minute, it's a lot, like, it's expensive at XYZ pharmacy, and they just show up on there. So if the local pharmacy is setting up better pricing than we're getting, the member's gonna know about it and plan will know about it as well. I'll let Chris talk about a program is not in place yet, but we think might be something you want to look at, like a Healthy Weight program.
We developed this earlier this year, the Healthy Weight program, in order to address the obesity epidemic that we've been dealing with in the country. I have on this first slide just kind of showing the incidence of that problem. Nationally, over 70% of adults are overweight, or 40% of adults are obese. I pulled this picture here on the side from the Texas Health and Human Services Department. Hidalgo County, where McAllen is located, has an obesity rate of 43%, which is higher than the national average. We're presenting this as here to gauge interest in this program. There is currently no weight loss coverage for any pharmacy medications through the benefit here. Obesity, it's not just causing high blood pressure and diabetes. It also can lead to heart disease, heart attacks. It can lead to dementia, osteoporosis, cancer, depression. There's a whole slew of comorbidities that are associated with obesity, so we think it is important to address this problem. On the next slide, we have this working, we have another client in New York that is similar to McAllen. They're just a bit smaller. They have about 1,500 members, and about 10%, or a little bit less than 10%, have utilized anti-obesity medications since they started with us. Those 132 members have increased the plan cost substantially. That plan has no restrictions whatsoever in treating obesity, so any medication they get written for to manage their that problem is just paid. They don't want any stops in it, so we allow it to go through, and I do record their weights to assess if the medications are working or not. We don't have data on that, because we did start doing that relatively recently, but the point is that this client has seen, due to the unrestricted access, increases in their plan spend of about 30%, because there are no stops in place to stop these from going through, and everyone is wanting to lose weight, look better. For McAllen, I based this off a little bit older member count, but if McAllen has 5,100 members, and I did some research, and I found about 3,100 members are over 18 years of age, which will qualify for these medications. Statistics say about 40% of those are obese, so let's say conservatively 1,800 members would qualify for these medications. It's a pretty substantial impact, and what we've done is, rather than suggest to McAllen to open up coverage of these anti-obesity medications, we built this Healthy Weight program to give a better solution than opening the floodgates. I'm going to go to the next slide. So what I'd like to gauge a reaction here and see what we're thinking. What we've done is I have the plan design would be adjusted to allow for anti-obesity medications to be dispensed for people that meet the criteria. There's no additional charge for this program or by Araya. There's obviously an increased pharmacy cost due to more medications being dispensed. But how this works is that you'd have to meet requirements to receive the anti-obesity medications, let's just say AOMs to be shorter, for the initial fill. And then every 12 weeks, indefinitely, you would get monitored for your weight to make sure the medications are working. If you still have BMI within a range, specific range, you're allowed to receive the medication, but you also need to show that it's working. It's not just a free, you have this as long as you want. You actually have to have success and skin in the game, really, to try and lose weight as well. We're requiring 1 pound per week of weight loss, which is in line with the CDC and the World Health Organization guidelines, saying this is, they recommend 1 to 2 pounds per week for weight loss is safe. We're saying we'll cover these medications if you lose at least 1 pound per week and show us that you're trying and dieting and exercising. This information is obtained via medicals from the prescriber, and in order to not increase the medical side spending, we don't need the member to go to the prescriber to visit. A phone call confirming to the prescriber saying their weight loss and just having the doctor record it in their medicals will be sufficient for our records for this 12-week mandatory review for these members if they were to get this medication.
So the program is an intermediary. We're not covering it all here right now.
Nope.
We certainly stay doing that. We have groups that are covering it without any guardrails whatsoever, and we've seen really big cost increases. We don't know if you're getting pressure from your membership or right now to cover these things. So you're probably getting asked, why are we doing that? So if there is a desire to look at something, here's the way we would suggest doing it. Without, as Chris said, making it open access.
Yeah.
With no controls in place.
Members are informed that via letters that they do have requirements to meet, goals to meet. So it's not a surprise you didn't lose the weight. You can't have your medication for 3 months, and then they're allowed to come back on it. It's not like a lifelong ban. They don't meet their requirements. There's a 3-month probation period where they can either talk to their prescriber, change medications, come up with a different plan, figure out why it didn't work, and then they can get the medications again. It's not just a flat approval.
Have we had a lot of requests or interest?
I wouldn't say a lot, but there's been more here lately with Ozempic in the news. And what's the name of the other one, Chris?
Manjaro?
So that Manjaro is,
Manjaro?
Yeah, Wegovy, yeah.
So
Wegovy,
interestingly enough,
Saxenda.
with Hovey being out on the field, she comes back and shares with me, that's what they're asking about. Are we covering this? If not, when? So there's more people asking, so absolutely.
The problem with Ozempic and stuff like that is, once you have your doctor say you're pre-diabetic so you can get it, then when you go out for health insurance or life insurance or everything, now your life insurance is more expensive because it says that you're diabetic. And so, yeah, you want to lose weight, but now the unintended consequences, now you're gonna be paying more for, I just don't think people think about all this.
But I think from what I heard also, I don't think it's Manjaro or Ozempic, I forgot which one my friend is the rep for, but they are going out for the FDA for obesity. So you won't have to be, as long as you have that BMI, which most of us do, then you qualify for the obesity diagnosis.
We're expecting, if this was implemented, costs would increase if you're getting more medications, right? Ozempic is available internationally. It's on back order currently because everyone wants it, right? So it is available, just not right now. So when that shortage is resolved, we should be able to get that at a lower cost internationally.
Yeah, it's more in the $500-$600 range.
Yeah, and that's assuming the rebates that have increased don't knock it off the electronics list, because that is reviewed every 3 months.
And what about the compounded formulation? So it's not the name brand, but
We don't cover any compounded formulations for that, because it's an FDA-approved, commercially available medication.
Okay.
I realize it's on back order, but it's not like there are no alternatives. Rybelsus is an oral medication that has the same ingredient as Ozempic is. So we had them use other alternatives rather than get a compounded Ozempic, because we found compounds made by pharmacies, they jack the price up to whatever they want, and we don't allow for that.
So you see this as a way to lower the cost, not allowing those drugs to get into our system, but using this as an alternative?
So it's kind of a middle ground, as Chris mentioned. So we're not saying it's covered and everybody can get it. One, it's a shortage, so that'd be problematic. Cost would go up for sure. So this would be like a middle ground where if you can meet certain criteria, we're saying you're eligible. So yes, costs will go up, but at the same time, we'd hope that some of those comorbidities
Would go down.
would go down.
Right, you would save on that side, but I fear there's gonna be like, oh, yeah, like so the doctor's office is gonna say I lost a pound, like you're gonna have to now go into the doctor's office every week or every month or every 3
That's what
months?
Chris said, is we let as long as it comes through a doctor, it could be self-reported. Eventually, they're gonna.
The member calls the prescriber,
Yeah.
they record it, so we know there's someone checking it. No one's gonna lose 50 pounds in 3 months, right? So they make sure it makes sense. There's no other way to do this besides have a bit of an honor system going on for that. But when they go to the doctor and have a real visit, and they see that they actually did not lose 50 pounds, then that should be reported as well. The doctors can't lie on their medicals. They can, but like.
They would. And so, the group that's, you told me before, that spent a lot of money, you're talking 30%, we've seen some really great results there too.
The cost
People have lost weight, and it's actually, it's a chain of health centers. So, it's prescribers, who are employees of it, as well as nurses and other health workers. So they all have great access, to getting a prescription written. And so we're telling them this is going to cost you a lot of money, and now they're going, oh, so they're actually they want to go back and start looking at the medical side to see, we know they've lost a lot of weight, have we seen the reduction? So we'll have some better data probably in 6 months on what's happening there. But we just want, again, we're trying to be in front of this, and if you get pressed on it, and say, all right, if we have to, if the members really want this, here's the way we can do it, then, thank us some dollar bills on it.
The idea is that if you have someone that has a BMI of 40, let's say, and they lose 100 pounds and have a BMI of 25 or 27, where your normal BMI is, and if they had diabetes before, they could stop taking their medications.
Yeah.
They could be done. They could
Save
have
so much money on the
they
other
could have
side.
they could have no need for knee surgery because they don't have osteoarthritis anymore because they have all the extra weight on every
Right.
single
Sleep
step they
apnea is
take.
gone,
Sleep
everything's
apnea.
gone.
So there is a real opportunity to lower medical costs and pharmacy costs down the road, but it is an investment that you need to make in order to get there, which is unfortunate, but that's the reality of it.
Oh, yeah, you mean just
Like
employees
just
only, not
employees,
members?
Right.
Or we
Is
can do
that
whatever you
allowed?
want.
Are you allowed to do that? Can you do
That's-
some stuff
That's
just
a
for
good
employees?
question. I'm not sure.
Because that's the way to do it.
Yeah,
That-
because if we really wanted to do it for our
Our
teachers, our
employees.
employees.
Yeah.
I'd have to look at that. I'm not
I
sure
don't
if that's a discrimination type
Label, Right.
provision. If you're on the plan, you're entitled to these
Everything the
plan
plan offers.
benefits.
Well,
But it
like,
could be a separate plan, possibly.
well, I know, like, I just did my health enrollment, like,
I like that.
an hour ago. And so I did, dental and then members included, and it was, myself and all my kids. And the same thing for vision. So I wonder if this health weight program is a section where it's member or employee-free. Dependents is
Right.
X amount
And
more
that-
out of your
And
check.
and that's kind of what I was suggesting, that maybe if it's a different plan, as you described,
Yeah,
then it would be an issue. We'd have it designated as such. There
Yeah.
might be a cost difference.
If it's
Right.
a different plan, could we have a different copay as well? We can cover half of the cost of medication instead of, your copays now are very generous.
It's a good thing.
I was thinking about it right now, and I was like, wait a
You
second, I have to
charge different
pay,
rates for
my
contributions.
vision and dental is free, but I have to pay for the kids and that.
Yeah,
So that's how.
yeah, no, that's fine,
We can look at that as an option.
yeah.
Any other questions?
I think that would be a great.
Thank you for your time, really appreciate it.
Well, and I think it's,
Thank
for
y'all
the-
very much.
Yeah,
Thank you for
thank you.
coming in town.
And that medication that it has worked for, it has changed over, right? Like,
Oh, yeah.
I was on it for a year and didn't. Good diet and everything, but then at least now I found out it's a whole other issue than I don't feel, but.
Can you send me an email? I'm gonna make sure.
If hypertension is a,
Get rid of all that.
right. Those are the two, so.
You have energy, you have, yeah,
And
everything.
those were the numbers that are.
Oh, I guess we do adjourn.
Adjourn.
Unless you have some other questions for us?
Sorry, I'm sorry, we are now at 1:04, we are adjourned.
Yes, ma'am.